This is a 81-year-old female, not frail, but she is a small lady, Fausto,
Hmm.
with 88 kilos, um, and her body surface area is 1.9. So, and she has also a small annulus. So she is a little bit of risk of
Hmm.
patient-prosthesis
Hmm.
mismatch. As relevant comorbidities, hypertension and dyslipidemia. She presented with symptoms of heart failure due to aortic stenosis. And on perioperative risk assessment, the EUR score 2 is 2%, and her STS is 3.9%. On lab tests, she has a thrombocytopenia. The renal function is normal. The GFR is 69, and she has a high level of BNP 1,100. And on echo, she has a tricuspid valve, very stenotic, with thickened and calcified leaflets. The peak gradient is 112. The mean gradient is 78 millimeters per mercury. And the aortic valve area was estimated as zero point 0.6 centimeters square. And she has also a preserved LV function with an ejection fraction of 64. And these are the CT findings. Maybe Alberto could go on what we found here.
Yes, of course. Thank you, Dimitri. So in the CT findings, we have an annulus diameter of 19 and 23, and a small annulus, as you told us before, smaller than 400 square millimeters. So her is 344. The valsalva diameters is 26, 26, and 27. So the LVOT is a small LVOT as well, from 18 to 22. The sphenotubular junction, we have extreme calcification, like 3,600 degrees of calcifications. The smaller diameter is 21. So the extending aorta is 26 to 29. The coronary heights are satisfactory, over 12. The implant view, the coplanar view, is 3 of ROA and 9 cranial. The angle is 35. For the femoral, we have small diameters in both sides, but the left one has less calcification, so we choose the left one to perform the TAVR.
So this is the echo about today in this patient. This is the apex view, and we have LV hypertrophic and stenotic and calcific aortic valve. We can see a point, a calcium point in LV outflow tract and the mitral annulus. In a short view, the patients don't have a good acoustic window, but the aortic valve is a tricuspid valve in three chambers with color Doppler. There's no obstruction of outflow systolic in the LV outflow tract. There are mild aortic regurgitation. The ejection fraction about 3D echo is 5.9%. The main gradient today is 88 millimeters mercury, and the LV area is 0.47 centimeters square.
Dimitri.
So we are going to perform this case with minimalist approach with conscious sedation.
Hmm.
We're going to use balloon expandable valve, and we're going to implant this valve using wire pacing.
Hmm.
One challenge here is to select the valve size because She has a small annulus. There is some calcification on the LVOT track.
Per close.
Yeah, this is our standard approach nowadays. We always puncture the femoral with ultrasound, and we're gonna use just one proglide for hemostasis.
So you.
And in about 70 to 80% of cases, we finish the case with just one
What?
proglide.
Okay, great. So
We
you.
already crossed the aortic valve,
Yeah.
and Alberto now is placing pre-shaped wire in the
What
apex.
kind is wire is this one?
So this is the confident wire.
Confident wire.
This is an
Oh,
important step to
to
be
do intervent.
careful about wire position.
Yeah.
So we check on fluoroscopy
Yes.
and we check on echo. This patient has a small left ventricle. So
And like we did last time, you can see here is like to pilot an airplane.
yeah.
We need to be uh, exactly under the rules. So the first one, you have a stiff wire in the LV and a small LV. You need to make sure about the position. Okay, go ahead, please.
So, as we told you before, we have a small annulus, we have a small calcification in the LVOT,
Uh-huh.
and we have the limit between the size of the valves. So
So
we
it's a
choose,
borderline
yeah, it's a
zone
borderline valve. So we choose
between.
based on area, the intermediate size, that's 21 and a half.
20 and a half. So
Yeah.
if you have a sapien trees, what size of valve would you use?
So you have to choose between the 21 with overfilled or the 23 underfilled.
Uh-huh.
So it's the operator decision.
So with the my valve, as I understood, you're going to choose a 21.5.
Yeah, we use the intermediate
Is
size.
there any advantage in doing this?
Yeah, you have a more tailored approach for the patient. I don't know if it will reflect in clinical impact,
Outcomes, yeah.
outcomes, but it is a tailored approach for the patient.
Okay, good. What is next? To look at the valve?
Yeah, let's go. I'll explain a little bit of the THV characteristics.
Uh-huh.
So it is a balloon expandable valve, as you can see, that has intermediate size
Uh-huh.
as a 21 and a half, 24 and a half, 27 and a half.
So,
We have extra large size, the 30 and a half and 32, in addition of the traditional size of 20, 23, 26, and 29. It has a bovine pericardium leaflet with an anti-calcification treatment. We have an external PET puffing to minimize the incidence of PVL. It has a nickel cobalt alloy frame that gives a good radial extrait and a great head opacity. We inserted before the sheath, the Python sheath. It is a expandable sheath, 14 frame expandable sheaths that is compatible with the all size of the THV from 20 to 32, but from 27 and a half on, we have to pre-dilate with the dilator, 18 frames dilator. The navigator system you can see here, it's a good, that has a good flexibility, and one single step, that's to do the deflection. Another great feature that the valve is crimped directly on the balloon, and it's able to retrieve in case of we cannot cross the annulus. So we have a radial opacity pattern that help us to position the valve in the annulus. So we basically use the second bands in the base of the pigtail catheter, and this positioning guarantees us at least 25% of ventricular positioning. So to move on,
Yeah.
I think we can check the valve positioning. We have to check it is an aortic position with the skirt distal in the navigator. And another thing we have to check is the volume in the
In the
the
flater, right?
the insufflator.
We have 15 ml, 15 cc here.
So I think we are good to go. If you're okay, Dr. Fausto and Dimitri.
Yeah. Okay.
So I'll take the loader off.
Alberto, how often do you usually predilate when you're going to use my valve?
Thank you, Dr. Fausto. In our experience, we usually predilate about 30% of the patients.
30%.
We do not do routinely predilation.
Okay.
We only predilate in particular scenarios, like bicuspid valve, small area, or when we have doubt about the sizing.
Mhm.
Let's do the deflection here.
Now it's deflection.
Okay.
Dimitri is doing
Okay.
this in his hand, and
I
Alberto
got the wire.
is advanced
Okay.
the valve, and Dimitri is holding the guide wire. Now it's close to the aorta. You're gonna see that.
Can I cross?
Yeah.
Is
Yes.
okay for you? So
Yeah.
let's go.
Dimitri, do you wanna make comments about the position?
Yeah. We tend nowadays to implant this valve a little bit higher just to prevent conduction disturbance and pacemaker need.
That's
So
okay.
What is
I
your reference, right?
sometimes we use RAO just
Mm-hmm.
to put the valve in a shallow position. We can make another angel here. Tá
Mm-hmm.
pronto aí a bomba?
Bomba tá pronta? Injeta.
Injeta. I think it's a good position, right?
Yeah, I think so.
Yeah. You think it's okay?
Yeah. Let's implant now. Marca passo
What
tá
is your
pronto?
reference to position?
So
Maybe
we
you can
have.
tell the audience.
Can you see, Dr. Fausto, in
Uh-huh.
the fluoro, we
Uh-huh.
have a first dance band,
Uh-huh.
a second light band, and
Uh-huh.
a second dance band.
Uh-huh.
Usually, we use the second dance band in the base of the pigtail catheter
Uh-huh.
that give us the 25% ventricular placement.
Okay.
So let's
Good
implant the valve.
explanation.
Liga o marca passo, por favor. 100.
Now the pacemaker. Can you have
Bomba tá
now
pronto?
the hemodynamics in the screen,
Deixa eu virar
please, if it's possible? Hemodynamics now.
180.
Hemodynamics,
Okay.
please. Okay.
Injeta.
So it's 180. We deploying the valve, as you
Okay,
can see
okay.
there, inflating the
Okay.
balloon.
Furou o balão.
Desliga o marca
Off,
passo.
deflated. Pacemaker off. And the
Yeah.
blood pressure is back again. The heart rhythm is okay. And pull back the
Can I take
balloon.
out then?
And now we have Andrea checking with echo. Andrea, what are the main findings that you look for in the echo after we place the valve? Please, Andrea, what are you looking for?
We look in the short view to see the
Pericardial effusion.
to see to see the prosthesis
Balão 20
about
para mim. Abre um
expansion,
balão 20. Abre um balão 20.
and
Could you say again, please?
in the short view
Mhm.
for about the prosthesis, about expansion the prosthesis,
Uh-huh.
and we put a color Doppler to look for a leak. In this case, it's
So
no leak. It's a very
No regurgitation.
no, it's
No
very
regurgitation.
minimal
Also,
regurgitation.
Can you have the
And
echo in the large screen, please, now?
it's important to see the pericardial.
Yeah.
She don't have a pericardial fusion.
Okay.
The
Fausto,
contractility and the
despite
gradient.
Andrea, despite the good result on echo at this point, we noticed that the balloon ruptured during
Yes.
implantation.
Yes, I saw that.
Yes,
Look at that.
So let me
I'm saw that
repeat
too.
the angel here.
I'm saw that too.
It's like a calcified
I think
lesion in a
it's
coronary artery.
Yeah.
yeah.
So we're gonna use a 20 balloon just to make sure that the valve
Uh,
is expanded.
okay. So we had the balloon rupture. Can you show the angel now, please, just to see when we expand the balloon and the rupture on life? Yes. Can you put the balloon, the movie, please? Play. Yes. If you look at this, I could see that. So now the valve is expanding with the balloon. So expanding, and then rupture, balloon rupture. Why did it happen, Dimitri? Do you have an
Maybe because
explanation?
of calcification.
Yeah.
the sinotubular junction was very calcified. It's
Yeah.
a small anatomy.
Hmm.
So maybe we gonna check echo again
Hmm.
and decide if
If
this
you
patient
should.
need pulse
Well,
dilation with a 20 balloon.
okay.
And maybe we can move to the another room just
Yeah.
to
Let's
decide, and
see.
then
Yeah.
we can come back.
Let's see. Maybe we can finish the procedure here. In 10 minutes we'll
Hmm.
be done. So, do you
So
have any gradient? Can you?
yes,
Okay.
we
Can you bring back the echo in the screen,
the
the large screen, please? With now you can have only
this is the
the
gradient.
camera. Can you open the camera in the room with the operators, please? And Andrea is talking about the gradient.
The big gradient is 16 millimeters mercury, and the
Could you
mean
say again,
gradient is
please?
8.
8 millimeters.
The main gradient 8.
I mean the maximum or the
The
The mean
maximal
is
is
8.
16. The maximal is 16,
thing and the
and the
median is
mean is
8.
8.
So you should maybe we should pose that later.
Yeah,
In Dimitri.
let's do an angio first,
Hmm.
just to check how the valve adapted to the
Okay,
anatomy.
Can you?
Dimitri, we're
Yeah,
thinking
we are
in
not in
going.
a hurry. Patient is very stable right
Uh-huh.
now with
Yeah.
diastolic pressure of 65. So let's check on angio and decide if the patient needs a pulse dilation.
Okay, can you bring the angel in the screen now, please? The angel.
We are not questioning the what Andrea just saw, but
Vamos preparar, bom?
just to know how the prosthesis adapts
So,
to the anatomy.
is there any um, rule and about the gradient? What is the minimal gradient that you accept? Not to pose dilate.
Usually with neurogeneration THV, maybe the mean gradient is 6 or 5
Okay. Now we have 8. It's a little
inches.
bit above. Do you
Yeah,
think we should pose dilate?
let's think about it.
Do you
Like
balance?
I said, there's no hurry. Patient is very stable. We're gonna check on angel
Okay.
also,
So
and
maybe we
maybe we
can.
can measure the gradients
Mhm. Okay.
before deciding.
Yeah. Maybe because we have 10 minutes here because we have a multi-vessel disease in the next lab.
Up
We
to
are
you,
gonna
Fausto.
finish.
If you want to move to
No,
another
no, no,
room and
no,
then
no. We stay here up and to finish the whole procedure,
so
and
let's measure the
we go there.
gradient. So
Okay. Do you always have this kind of preoccupation and to do the post dilation?
yeah, yeah.
Yeah, I know that. I can feel
Pulse
that.
dilation is not 100% safe.
Hmm.
It's associated with risk of stroke, for example,
Pouquinho.
So,
and
and if you measure, you balance this, the mean gradient is about 8.
yeah,
You're gonna see now here. So
there
you have
there's a risk
no
of a
no
pacemaker
regurgitation.
need. So
Yes, no regurgitation, and there
It's
are
a mild paravalvular leak.
mild,
Mild.
mild paravalvular leak. Okay, let's see what.
let's see the hemodynamics.
Okay, just
She
a
do
minute.
the
So peak gradient is
gradient
about
intra.
5 maximum
Mhm.
on hemodynamics, right?
You know,
Five,
if you
7.
ask my opinion, the patient is
She do
81 years.
gradient in output prepped.
Yeah.
Is better.
It's not so
Let's
far.
do an angel.
So the patient is 81. Now, can you bring the angel, please, in the screen? We are going to do an angel. Just wait a little bit. Okay, we have the angel now.
Jetta.
Yeah, no regurgitation. No regurgitation.
Yeah.
So, so the mean gradient is below 5.
The peak gradient is now it's around 8,
8, yeah.
and by echo is 8
Hmm.
millimeters. There's no aortic regurgitation.
Hmm.
Um, I think we got a
If you
good
ask my
result.
opinion, I would stop. Do you agree, Alberto?
Yeah, I do agree. I
Yeah.
think we have a good
I think
result.
good results in echo, good results with the hemodynamics, no, just mild aortic regurgitation, and we cannot see in the angel. I would stop.